This recorded lecture will be going over Chapter 27, The Child with the Condition of the Blood-Forming Organs or Lymphatic System. On page 639, figure 27.1 summarizes some of the differences between the child's and the adult's lymphatic systems. On page 639, within figure 27.2, you can also read more about the main types of blood cells in the circulating blood. Much of this will be a review for MedSurg. Petechiae and purpura are often conditions that should alert the nurse to the possibility of blood dyscrasias. Anemia can result from many underlying causes. The most common nutritional deficiency of children in the United States today is anemia caused by insufficient amounts of iron in the body. The highest incidence of iron deficiency anemia occurs from the 9th to 24th month. Cow's milk contains very little iron. The symptoms of iron deficiency anemia are pallor, irritability, anorexia, and a decrease in activity. Untreated iron deficiency anemias progress slowly, and in severe cases, the heart muscle becomes too weak to function. If this happens, heart failure follows. Iron, usually ferrous sulfate, is administered orally 2 or 3 times daily between meals. Vitamin C aids in the absorption of iron. The toddler will need solid foods that are rich in sources of iron. Parents will need explicit instructions on proper foods for the infant. The stools of infants who are taking oral iron supplements will appear tarry green. Oral iron preparations are not to be administered with milk, which will interfere with absorption. Sickle cell disease is an inherited defect in the formation of hemoglobin. Sickling caused by decreased blood oxygen levels may be triggered by dehydration, infection, physical or emotional stress, or exposure to the cold. Sickle cell trait will not develop into sickle cell disease. Sickle cell anemia is a severe form of the disease that results when the abnormality is inherited from both parents. There is chronic anemia present. The child is pale, tires easily, and has little appetite. These manifestations of anemia will be complicated by characteristic episodes called sickle cell crises. These are painful and can be fatal. Children with sickle cell disease have a risk for stroke as a complication of a vaso-occlusive sickle cell crisis. On page 642 within table 27.1, you can read about the various types of sickle cell crises. The sickle cell crises will recur periodically throughout childhood. However, they tend to decrease with age. Immunizations of these children are particularly important, including those for Haemophilus influenza, hepatitis A, and hepatitis B, as well as the pneumococcal vaccine. The sickling test is commonly used for screening. When the infant or child is hospitalized during a crisis, treatment is supportive and symptomatic. Oral hydroxyurea with once daily dosing is the only drug treatment for sickle cell disease approved by the FDA. Maintaining adequate hydration is important, and sodium levels should be monitored because hypernatremia can dehydrate red blood cells and increase sickling. The nurse must remember that pain experienced by a child with sickle cell disease may also be caused by an unrelated condition. Prevention of infection and prevention of dehydration are important goals in the care of a child with sickle cell disease. The main goals of nursing care are to observe for sickling, dehydration, hypoxia, and infection, which could all cause a sickle cell crisis. Routine splenectomy is not recommended. Hematopoietic stem cell transplantation can cure sickle cell disease, but this therapy is currently available only to those with a human leukocyte antigen compatible sibling. The thalassemias are a group of hereditary blood disorders in which the patient's body cannot produce sufficient adult hemoglobin. This abnormality results in chronic anemia. Thalassemia minor, which is also termed beta thalassemia trait, occurs when the child inherits a thalassemia gene from only one parent. It is associated with mild anemia. Thalassemia major, also called Cooley's anemia, occurs when 2 thalassemia genes are inherited. A progressive, severe anemia becomes evident within the second 6 months of life. The child appears pale and hypoxic, has a poor appetite, and may have a fever. Diagnosis is aided by a family history of thalassemia, radiographic bone growth studies, and blood tests. The goals of care for children with thalassemia are to maintain hemoglobin levels at 9.5 grams per deciliter to prevent the overgrowth of bone marrow and resultant deformities, and provide for growth and development and normal physical activity. Prevention or early treatment of infection is important. The mainstay of treatment for thalassemia major is frequent blood transfusions to maintain a hemoglobin level above 9.5 grams per deciliter. Nutritional support is essential. Children are taught to regulate their activities according to their own tolerance. The family can be referred to the Cooley's Anemia Foundation for support and education. Bleeding disorders. In this disorder of hemophilia, the blood does not clot normally, and even the slightest injury can cause severe bleeding. Hemophilia is inherited as a sex-linked recessive trait. There are several types of hemophilia. The two most common types of hemophilia are hemophilia B, or Christmas disease, and hemophilia A. Hemophilia A can endanger some patients' lives by minor injury, whereas a child with a mild case of hemophilia may just bruise a little more easily than the normal person. The aim of therapy is to increase the level of factor VIII high enough to ensure clotting. In a patient with severe hemophilia, however, the time required for clotting may be 1 hour or longer. Hemorrhage into the joint cavity, or hemarthrosis, is considered to be a classic symptom of hemophilia. In a newborn with a family history of hemophilia, circumcision, heel sticks, and intramuscular injections are delayed to prevent bleeding and tissue injury. The principal therapy for hemophilia is to prevent bleeding by replacing the missing factor. When bleeding does occur, the traditional approach to care includes rest, ice, compression, and elevation. A medical alert identification band should be worn at all times. Allowing children to participate in their decision-making about care and focusing on their strengths is helpful. Skin lesions that are common to these disorders of platelets include petechiae, a bluish, non-blanching pinpoint-sized lesion, purpura, groups of adjoining petechiae, ecchymosis, an isolated bluish lesion larger than petechiae, and hematoma, a raised ecchymosis. Idiopathic thrombocytopenic purpura is an acquired platelet disorder that occurs in childhood. ITP occurs in all age groups, with the main incidence occurring between 1 and 4 years of age. The classic symptom of ITP is slowed blood clotting and easy bruising, which result in petechiae and purpura. When platelet counts are low, the greatest danger is spontaneous intracranial bleeding. Neurological assessments are therefore a priority of care. Treatment is not indicated in most cases of ITP. HSP is a vasculitis, and it occurs in 14 to 20 out of 100,000 children per year between the ages of 3 and 10 years of age. It is an autoimmune illness that involves inflammation of the blood vessels with multi-organ involvement, and signs and symptoms of petechiae and palpable purpura and ecchymosis, mostly in the lower extremities. The treatment of cancer in children due to irradiation, surgery, and chemotherapy will often have adverse effects on growth and development. Leukemia is a malignant disease of the blood-forming organs of the body that results in an uncontrolled growth of immature white blood cells. Leukemia is the most common form of childhood cancer. The most common symptoms during the initial phase of leukemia are low-grade fever, pallor, bruising tendency, leg and joint pain, listlessness, abdominal pain, and enlargement of the lymph nodes. It could have a gradual or sudden onset. The diagnosis of leukemia is based on the history and symptoms of the patient and the results of extensive blood tests that demonstrate the presence of leukemic blast cells in the blood, bone marrow, or other tissues. As with any diagnosis of cancer, the child with leukemia is usually referred to a specialized center where facilities for required care are available. Presenting the child's favorite foods in an attractive manner can help stimulate the appetite. The nurse should refer parents to available support groups. A bone marrow transplant could be useful. When the child is hospitalized, protective environmental precautions and transmission-based precautions may prevent healthcare-associated infections. Children's anxiety will often center on their symptoms. Nurses must inform children of what they are about to do and why it is necessary. The pediatric nurse who encourages patients to discuss their concerns will find opportunities to clear up misconceptions and to decrease children's feelings of isolation. Nutritious meals and supplemental feedings that are high in protein and calories are offered. Thrombocytopenic bleeding is a common complication of leukemia. The nurse observes the patient's skin for petechiae and ecchymosis. Platelets and packed red blood cells can be given to the child, but blood should be administered slowly. Circulatory overload is always a danger with children. Dyspnea, precordial pain, rales, cyanosis, dry cough, and distended neck veins will indicate circulatory overload. It is helpful if the parents remain with the child during this time. Hodgkin's disease is a malignancy of the lymph system that primarily involves the lymph nodes. Hodgkin's disease is rarely seen before 5 years of age. The presenting symptom of Hodgkin's disease is generally a painless lump along the neck above the clavicle. Diagnosis will be confirmed by excisional biopsy of the node. Radiation, therapy, and chemotherapy are used in accordance with the clinical stage of the disease. Nursing care is mainly directed towards symptomatic relief of the side effects of radiation therapy and chemotherapy. The school nurse should be contacted to implement a schedule that will promote growth and development while preventing overfatigue. Nurses must be particularly prepared for periods of anger, which may be directed at them. Adolescents may be interested in sperm banking before immunosuppressive therapy is initiated. Chronic illness during childhood will often affect growth and development. You can read a bit more about this on page 651 within Table 27.3. Hospital school programs will provide familiarity and enable patients to keep pace with their classmates. Nurses must help patients to accept their body with all its strengths and imperfections. Most children with acute and chronic conditions can be cared for in the home. The chronically ill child must be a contributing member to the family unit. The child must be treated normally and overprotection and excessive restriction avoided. The child should be integrated into, rather than isolated from, the community and society. The nurse must understand the grieving process, personal and cultural views concerning that process, the views of a parent losing a child, and the perceptions of the child facing death. The nurse can facilitate the grief process by anticipating psychological and somatic responses and maintaining open communication. Nursing priorities include being a patient advocate and family advocate, providing support and facilitating the grieving process. Nurses must recognize that coping is an active and ongoing process. Expressing feelings is encouraged. Children should be allowed to have as much control as possible regarding what happens to them. Including them in decisions concerning their welfare will foster this control. Although age is a factor, the child's level of cognitive development, rather than chronological age, will affect the response to death. Children do not develop a realistic concept of death as a permanent biological process until 9 or 10 years of age. You can read a bit more about this within the Nursing Care Plan 27.1 that specifies nursing interventions for the dying child. You can also read a bit about a child's response to a sibling's death in the health promotion box on page 653. The stages of dying as detailed by Kubler-Ross: denial, anger, bargaining, depression, and acceptance, as well as reaching out to help others, can be applied to parents and siblings as well as the sick. Nurses should be available and should make their availability known. You can read a little bit more about how to do this on page 655 within box 27.1. It is therapeutic for children to be in their own surroundings whenever possible.